Hello everyone, this is Dr. Arash Hashemi, interventional cardiologist from Irfan General Hospital. Our today's case is outside of the box thinking when extreme support is needed. Our patient is a 16-year-old male with JCTO score 4 with 2 previous failed attempts, 1 failed retrograde approach due to inability of wire crossing, and he was referred to us for a third retry. This is the diagnostic angiography. As you can appreciate it, there's a relatively normal left system with a couple of septal retrograde collaterals, which are not very favorable because of the severe tortuosity. And you can appreciate the tortuosity in here better. There's a small epicardial collateral, which is always one of the last options. And this is the right system. As you can see, there's a relatively short CTO with heavily calcification, blunt proximal cap, and a vessel in the vicinity of the proximal cap. But the good point in here is that the relatively straightforward pathway of the vessel here is obvious, and you can appreciate there is a very, very short CTO. So what is the best approach to this patient? We can always do retrograde approach, which is not a first option in this patient due to the severity of septal tortuosity. We can do antegrade dissection re-entry approaches with crossbus or ADR, IVUS guided, or without IVUS guidance, or we can use BAM. And as always, we can do some antegrade microchannel surfing, which is always a good idea because sometimes there are little microchannels that you can see, but even you can't see them, but the wire passes real easily. So our main option is to go antegrade in this patient, but the main problem is that, as you can see, you need a very good support to puncture this proximal cap, and you won't get it from this guiding. And this is due to relatively short distance between the CTO proximal cap and the proximal ostial part of the vessel. Always when we have a CTO which is very, very near to the ostial part, we always have issues of support. Fortunately, there is a good collateral here, and this vessel can be used for anchor ballooning techniques. And as you can see, we put a wire in the left system to stabilize the guiding. And we started by trying to puncture this with a wire in the sub-branch. We tried with anchor ballooning here, but always the guiding, as you can see, backed up because of the lack of the support. So we did try with dual lumen microcatheter. We didn't have any luck. In this point was lack of support for penetration and guiding backed up. So what is the best solution here? Do we give up and go for retrograde? We can always change to AL guiding or mother and child technique for external support, but in this case, because of the very, very short distance between the ostial part of the RCA and the proximal cap, it won't help us a lot. Using dual lumen microcatheters and using anchor balloon side branch, always both are very good and valid ideas. We tried them and failed. And we can always do super anchor system with 2 guidings and jailing a wire in the side branch through the 1 guiding. But our understanding was it doesn't gonna change anything in this patient. So we did something relatively new, and we did balloon trapping of the microcatheter with a very large balloon inside the mother vessel. And as you can see, this is the same guiding, a wire in the subsidiary vessel, and we anchored the Corsair Pro with a very large NC balloon, 3x12. Very high pressure, and this stabilized the guide and give us the much needed support to try and penetrate and puncture this with Conquest Pro 12. After puncturing with Conquest Pro 12, we downgraded, we advanced a little bit and then pushed our microcatheter through the proximal cap, and then we changed and downgraded to Gaia third. And as you can see, the microcatheter went through. We are in a good position, and we downgraded to Gaia third, and we tried to continue the case, but we had a little complication. I will let it run for a couple of times and see if you find out what happened here. So look closely in this area. So what happened is we had a large clot in the left system even though that our wire was in the L6 and our ACT at this point was over 300. So we wired the lift system very quickly. We did integralin injection, thrombosuction, clots were resolved, and then we did IVUS run. We didn't have any pathophysiology that needed stenting, so we got back to the right system. Again, this is after thrombosuction and integralin and IVUS run. So our Gaia wire is off course here, which is obvious, so we pulled back and tried to redirect this, and after a little while we entered the vessel. After that, the rest was not that hard. We did the usual stuff, trapping, microcatheter advancement with anchor balloon, and after wiring the distal, we removed the micro and we put one stent in here. Very perfect result. Thank you very much for your attention.